Welcome back to the deep dive. Today we're taking a closer look, really getting into the source material, specifically Bailey and Love's latest edition.
That's right.
We're focusing on a particular weakness in the abdominal wall. It's structurally fascinating, but also carries a disproportionately high risk.
A silent threat, really. 1 minute it might seem minor, the next a critical emergency.
Exactly. So let's define our terms first. A hernia, broadly speaking, is just tissue pushing through a layer that's supposed to contain it, right? An abnormal protrusion.
Correct. But today, we're zooming in. We are focusing exclusively on the femoral hernia.
And why this one specifically?
Because it exploits a sort of natural design flaw, the femoral canal. And unlike some other hernias, this one comes with a very specific, very immediate danger built right into its anatomy.
Right, and that's our mission today, isn't it? To explain why this particular hernia, even though it's statistically less common than, say, the inguinal type everyone knows.
Much less common, yeah.
Why it demands such urgent, non-negotiable attention. We really need to unpack the facts that make it so unique.
And the facts from the sources, like Bailey and Love, are pretty stark. The femoral hernia uses the femoral canal, a space really only meant for small vessels, lymphatics.
Not bowel.
Definitely not bowel. And crucially, the opening, the neck of this hernia, it's surrounded by rigid, unyielding structures. It simply doesn't stretch.
Which leads to that statistic.
The really shocking one, yeah.
Yeah.
A staggering 50%, half of all femoral hernias, present for the first time as an emergency. Usually because of strangulation. The risk is just that high, that fast.
Wow, 50%. That number alone just shifts the whole perspective, doesn't it? It's not routine. It means immediate action is needed.
Absolutely. It confirms the universal surgical rule. All femoral hernias must be repaired. Period. As soon as you find one, the clock starts ticking. Urgently.
Okay, so to really get why it's so urgent, we need to understand the anatomy. Visualize the trap itself, you said.
Exactly. The danger is inherent in how the femoral canal is built. It's a tiny space, maybe only, 1.25 centimeters wide, tucked away just medial to the big femoral vein in your upper leg, right under the inguinal ligament.
So it's not like a tear muscle. It's an existing anatomical channel being, well, misused by the hernia.
Precisely. A potential space that becomes a real problem.
Okay, so paint the picture for us. What forms the walls of this rigid little box?
It really is a box and a very unforgiving one. Let's map it out. If you look anteriorly, so towards the front and slightly superiorly, you've got the inguinal ligament. That's a strong fibrous band.
Okay, the front wall.
Then laterally, right next door, is the femoral vein, a major blood vessel. And protecting this vein is absolutely paramount during any surgery in this area. You cannot damage it.
Makes sense. Front and side covered. What about the back, the floor?
Posteriorly, it's rock solid. You've got the pelvic bone itself, specifically the superior pubic ramus, reinforced by the iliopectineal ligament. You might also hear it called Astley Cooper's ligament. Basically, bone and strong ligament, no give whatsoever in that direction.
Okay, a rigid front, side, back. But you mentioned a bottleneck. Where's the specific part that really tightens the noose, so to speak?
That's the medial boundary. And this is the real villain of the piece. It's formed by the lacunar ligament, also known as Gimbernat's ligament.
Lacunar ligament. And what makes it so bad?
Unlike the other borders, this ligament has a very distinct shape. It curves inwards, creating a sharp, unyielding edge facing the femoral canal. It's like a knife edge, almost.
So if something like a loop of bowel pushes through the canal?
It slams right up against that sharp, fibrous edge. And the lacunar ligament doesn't budge. It acts like a natural tourniquet, or a choke collar, as you said.
And that immediately cuts off blood flow.
It impedes the venous return first. Blood can get in via the artery, but it can't get out easily via the compressed veins. The pressure builds up, the tissue swells, and very quickly the arterial supply gets cut off too. It's strangulation.
And unlike, say, an inguinal hernia where maybe there's some muscle that could give a little.
Exactly. Here, it's ligament against bone and other ligaments. It's incredibly rigid, this rapid compression leading to tissue death or necrosis. It can happen within hours. That's why that 50% emergency rate makes terrifying sense.
Okay, that anatomical breakdown is crucial. So the structure itself sets the stage for disaster. Now, who is most likely to encounter this problem? Is there a specific demographic?
There is, and it's quite distinct. While femoral hernias are less common overall than inguinal ones, they are significantly more common in women than in men.
Really? How much more common?
The figures vary a bit, but Bailey and Love suggests it's around 6 times more frequent in women than another type of hernia more common in women, the obturator hernia. So there's a definite sex bias.
Why is that? Is it anatomical?
It seems to be, yes. It's thought that the female pelvis, being generally wider and shaped differently for childbirth, creates a slightly larger potential opening for the femoral canal. The angle might be less acute, it just gives a bit more anatomical opportunity, unfortunately.
An inherent predisposition then.
Seems like it.
And within women, does it target a particular group?
Yes, the classic textbook presentation, and what surgeons often see, is the thin, elderly woman.
Thin and elderly, why that combination?
Couple of factors. Firstly, tissues tend to lose some elasticity and bulk with age, so that potential space, the femoral defect, can naturally enlarge over time. Secondly, in thin individuals, there's less subcutaneous fat and supporting tissue in the groin area. Less padding, if you like.
So less natural reinforcement around that already vulnerable spot.
Exactly. The lack of cushioning combined with age-related tissue changes makes the defect more susceptible to something pushing through, especially if intra-abdominal pressure increases.
Okay, so we have this dangerous anatomical trap, mainly affecting older, thinner women. But here's where it gets even more problematic, right? Diagnosing it is notoriously difficult.
Oh, absolutely. This is where the silent part of the silent threat really comes in. The clinical diagnosis is often missed, leading to dangerous delays.
Why is it so easy to miss? Location.
Location's a big part of it. Unlike a typical inguinal hernia, which bulges more directly in the groin crease, the femoral hernia emerges below the inguinal ligament and often lateral to the pubic tubercle.
Below and lateral, so it might actually appear more on the upper thigh than in the groin itself.
Precisely. It can present as a lump in the proximal leg, the very top of the thigh. And if you, the examiner, don't specifically look and feel for it there with adequate exposure,
You'll miss it, especially if the patient is just pulling down their waistband a little bit in a busy clinic.
that's a huge factor. Inadequate exposure is a major reason for misdiagnosis, but it's not just location. Another classic sign of a hernia is often absent.
You mean the cough impulse, the bulge getting bigger when the patient coughs or strains.
Exactly that. Because that lacunar ligament creates such a tight grip almost immediately, the contents get trapped. The hernia becomes irreducible. You can't push it back in. And critically, it loses any cough impulse.
No cough impulse.
None. When the patient strains, nothing happens. The lump just sits there, fixed and tense.
Okay, that's a massive diagnostic problem. A fixed lump, potentially in the upper thigh, no cough impulse. If it doesn't behave like a typical hernia, what does it get mistaken for?
The most common misdiagnosis by far is a lymph node.
Ah, because there are lymph nodes in that area anyway.
Yes, the femoral canal itself is a pathway for lymphatics from the leg. There's even a specific node often mentioned, the node of Cloquet, which sits right near the entrance of the canal.
And femoral hernias are often small initially.
Often just 1 or 2 centimeters. So you have a small, firm, sometimes tender lump in an area known for lymph nodes. It's incredibly easy to just assume it's a reactive or inflamed node.
And that assumption leads to delay.
Critical delay, potentially allowing strangulation to progress.
Okay, so small size and normal anatomy conspire against easy diagnosis. What if the hernia gets bigger? Does that make it clear?
Not necessarily. Sometimes, as the hernia sac enlarges, it doesn't just bulge outwards. Because of the surrounding structures, it might actually track upwards, folding back on itself to lie over the inguinal ligament.
So it ends up higher in the groin.
Yes. And when that happens, it can look very, very similar to a direct inguinal hernia, which arises just a bit superior and medial to the femoral canal. Distinguishing them clinically at that point can be extremely difficult. You might need imaging or even exploration to be sure.
Which brings us to maybe the most dangerous scenario of all with this hernia, the Richter's hernia. That sounds particularly insidious.
It is. It's named after an 18th century surgeon, August Richter. A Richter's hernia is when only part of the circumference of the bowel wall gets trapped in the hernia sac. Not the whole loop, just a knuckle or an edge.
Like pinching just the side of a balloon, not the whole thing.
Exactly. And the clinical implications of this, as the sources emphasize, are huge and potentially lethal.
Why? If only part of the wall is trapped, what happens to the symptoms?
Because the entire lumen, the channel through the bowel, is not blocked. The patient often doesn't develop the classic signs of bowel obstruction.
No vomiting, still passing gas.
Potentially, yes. They might not have nausea or vomiting. They might still pass wind, maybe even have bowel movements. The flow through the gut isn't completely stopped.
But the trapped piece of bowel wall.
That piece is still being choked by the tight femoral neck, by that lacunar ligament. It's still losing its blood supply. So while the patient might just feel unwell, maybe have some localized pain at the lump.
They don't have the dramatic, alarming symptoms of a complete blockage that would usually scream emergency.
Precisely. The lack of obstruction masks the severity. But meanwhile, that trapped segment of bowel wall is becoming ischemic, then necrotic gangrenous.
And if that dead piece of bowel perforates.
Then you get leakage of bowel contents. That leads to severe infection, maybe an abscess, cellulitis, or even widespread peritonitis and sepsis. And it happened because the diagnosis was delayed, because the usual alarm bells of obstruction weren't ringing.
So the mortality rate for a Richter's hernia that gets missed must be significantly higher.
It is dramatically higher. The patient often comes to surgery late, already septic, because the initial picture wasn't clear. And because the femoral ring is so inherently tight, it's actually quite prone to causing these Richter's-type strangulations. It's another reason this hernia is so dangerous.
Okay, this combination, difficult location, no cough impulse, potential for a masked Richter, it really demands a high index of suspicion from the clinician. What else needs to be on the list of possibilities when someone presents with a lump down there?
The differential diagnosis is pretty broad, yeah.
Yeah.
You have to think about everything in that neighborhood. Obviously, an inguinal hernia needs distinguishing. We mentioned the lymph node. Another important one is a saphenous varix.
What's that?
It's a varicose dilatation, a swelling of the top end of the great saphenous vein, right where it joins the femoral vein.
How do you tell that apart from a femoral hernia?
Key difference. A saphenous varix usually does have a cough impulse. It might transmit a thrill if the patient coughs, and it's typically easily compressible. It disappears when the patient lies down and you press on it. An irreducible femoral hernia won't do that.
Good distinction. What about blood vessels themselves?
Absolutely. You have to consider a femoral artery aneurysm, a bulge in the artery wall. That would be pulsatile. You'd feel a pulse in the lump, which you wouldn't with a hernia.
Okay. Any less common things?
Rarer, but important to keep in mind, are things like a psoas abscess pus tracking down from the spine along the psoas muscle sheath, which can present as a groin swelling, or even a musculoskeletal injury, like a rupture of the adductor longus muscle with a resulting hematoma, a blood clot.
So a lot to consider. Given that the physical exam can be so tricky, what role does imaging play? Is ultrasound or CT helpful?
Hugely helpful, especially when there's uncertainty. For straightforward elective cases where you're pretty sure clinically you might not need imaging. But given all the diagnostic pitfalls we've discussed,
Uncertainty is common.
very common. Ultrasound is often the first step. It's non-invasive, readily available. It can visualize the lump, see if bowel is present, check for blood flow. Its main limitation is that it's very operator dependent. The quality of the scan depends a lot on the skill of the person doing it.
Right. But where imaging really shines is in that 50% emergency group, right?
Absolutely. In the acute setting, especially if the patient has signs suggesting bowel obstruction, imaging becomes critical. Plain x-rays might show dilated loops of bowel with air fluid levels, confirming obstruction, but they won't necessarily tell you the cause.
So what's the key takeaway for clinicians facing unexplained bowel obstruction?
The absolute key message is, every single patient with unexplained small bowel obstruction must have a thorough examination, specifically looking for a femoral hernia. Feel carefully below that inguinal ligament.
And if the exam is negative or you're still not sure?
Then a CT scan is usually the next step, and often mandatory.
Why CT in particular?
CT is excellent at showing the detailed anatomy of the groin and pelvis. It can pinpoint the transition point of the obstruction, and very often it will clearly show a small, strangulated femoral hernia, maybe even a Richter's type, that was completely missed on clinical exam. It can be truly life-saving in confirming the cause and directing the patient straight to surgery.
So it cuts through the clinical ambiguity, especially in those high-risk situations.
Exactly. It moves from being just confirmatory to being a primary diagnostic tool in emergencies.
Okay, let's pivot to the inevitable next step then. Surgery. Given everything we've said about strangulation risk, there's no wait and see with femoral hernias, is there?
Absolutely not. There is no alternative to surgery. It's always treated with urgency because the risk of complications is just too high.
And the surgical approach isn't one size fits all, is it? The sources mention 3 distinct open approaches. Why so many?
The different approaches really reflect the spectrum of presentation. Are we dealing with a small, reducible, elective case with healthy bowel? Or are we dealing with an acute emergency where the bowel might be dead or dying? The suspected state of the bowel dictates the approach.
Let's start with the simplest one, for the low-risk elective scenario.
That would be the low approach, often called the Lockwood operation. The incision is made directly over the hernia bulge, below the inguinal ligament. It's the most direct route.
Simple, maybe even local anesthetic?
Often, yes. It minimizes tissue disruption. The repair itself usually involves stitching the inguinal ligament above to the pectineal ligament, Cooper's ligament, below, effectively closing off that femoral ring.
Sounds straightforward, but there must be a catch related to that tight anatomy we discussed.
There's a huge catch. The Lockwood approach is only safe if you are absolutely certain there is no risk of needing to resect bowel.
Because you're working through that tiny, rigid opening.
Precisely. You have very limited space and visibility within the femoral canal itself. A surgeon might need to very carefully nick the edge of the lacunar ligament to help reduce the hernia. And even doing that carries risks, like hitting an abnormal obturator artery, the corona mortis, which sometimes runs there. But trying to safely cut out a piece of compromised bowel and sew the ends back together anastomosis through that tiny hole, it's just not feasible or safe.
So if there's any doubt about the bowel's viability, Lockwood is out.
Absolutely out. You need better access.
Okay, what's the next step up in terms of access?
That would be the inguinal approach, sometimes called the Lothesan operation. Here, the incision is made above the inguinal ligament, similar to a standard inguinal hernia repair.
So you come at it from above the problem.
Sort of. You go through the inguinal canal to reach the extraperitoneal space, the layer just outside the main abdominal cavity lining, the peritoneum. From there, you can find the neck of the femoral hernia sac from above and gently pull the contents back, reducing it.
Does that give you more room to work?
It does, and it's a very effective approach, especially for elective repairs. It also allows for placement of a mesh patch over the defect from this extraperitoneal position, which is a standard way to reinforce the repair.
Okay, sounds robust for elective cases, but what about the real emergency? The 50% presenting with likely strangulation, we need guaranteed access to deal with potentially dead bowel.
For that scenario, the gold standard open approach is the high approach. This is often referred to as the McEvedy operation, or sometimes the Nyhus modification of it.
McEvedy or Nyhus. How does that work?
This involves an incision made even higher, well above the inguinal canal, often a vertical or lower midline incision. The surgeon goes directly into the peritoneal space or even the peritoneal cavity itself. They're essentially approaching the hernia entirely from the inside.
Coming at it from within the abdomen, basically.
Yes, and this inside-out approach gives two critical advantages in an emergency. First, it allows a wide, clear view. The surgeon can open the peritoneum generously and directly inspect the entire loop of bowel that was trapped. They can assess its viability properly. Is it pink and healthy or dusky and dead? Second, and crucially, if the bowel is necrotic.
They have the space to deal with it.
Exactly. Operating within the main abdominal cavity provides ample room to safely perform a bowel resection, and anastomosis cut out the dead segment, so the healthy ends together. That is the key advantage, and why it's the standard for suspected strangulation. You simply cannot do that safely or adequately through the narrow confines of the low Lockwood approach.
So the surgical decision boils down to risk assessment. Bowel looks okay, maybe Lockwood or Luthison. Bowel looks compromised. You absolutely have to go high with McEvedy.
That's the fundamental open surgery triage for femoral hernia. The risk profile dictates the incision and the access.
Now, what about minimally invasive surgery? Laparoscopy is common for inguinal hernias now. Does it have a role here?
It certainly does, and its role is growing, especially for elective reducible femoral hernias.
Which techniques are used?
The two main laparoscopic approaches are TEP, totally extraperitoneal, and TKP, transabdominal peritoneal. Both aim to place a mesh patch over the femoral defect from the inside, covering the hole, but they get there slightly differently.
Can you quickly outline the difference?
Sure. With TEP, the surgeon creates a working space outside the peritoneum, between the abdominal muscles and the peritoneal lining, and places the mesh there without ever entering the main abdominal cavity.
Okay, stays outside the belly cavity.
Right. With TAPP, the surgeon goes into the abdominal cavity first with the camera, takes a look around, and then creates a flap in the peritoneum, dissects down to the hernia defect, places the mesh, and closes the peritoneal flap over it.
So TAPP involves going inside the abdomen first.
Yeah. Yes. And that difference is important, especially when considering emergencies.
How so? Is laparoscopy being used for emergency femoral hernias?
Increasingly, yes, particularly the TAPP approach. Because TAPP starts by looking inside the abdomen, the surgeon gets an immediate view of the trapped bowel.
Ah, so they can assess viability right away.
Exactly. If the bowel looks healthy after being reduced laparoscopically, they can proceed with the standard TAPP mesh repair. If the bowel looks non-viable,
They know immediately and can convert.
they can convert to either a laparoscopic bowel resection or an open resection through a small incision, having already confirmed the diagnosis and the need for resection minimally invasively. It offers a potential diagnostic and therapeutic advantage in some emergency cases.
The sources also highlighted a specific benefit of laparoscopy for women related to those diagnostic challenges we talked about earlier.
Yes, this is a really key point. Laparoscopy is often recommended, particularly in women undergoing hernia repair, because it provides an excellent view of the entire pelvic floor from the inside.
So you can see all the potential hernia spots.
Precisely. You get a clear view of the openings for indirect inguinal, direct inguinal, and femoral hernias. Historically, a significant cause of hernia recurrence, especially in women, was misdiagnosis fixing an inguinal hernia when the real problem was an undetected femoral hernia, or vice versa.
Laparoscopy avoids that.
It eliminates that diagnostic ambiguity. The surgeon can definitively identify the correct defect, or sometimes multiple defects, and repair exactly what needs repairing. This seems to lead to better long-term outcomes and lower recurrence rates, particularly in women where femoral hernias are more common and easily missed.
Okay, this has been incredibly detailed, a real deep dive into why this specific hernia is such a concern. Let's try and summarize the absolute key points for you, the listener.
Right, so the femoral hernia, it might be small, it might be subtle, but it's a uniquely dangerous condition. Its threat level comes directly from the anatomy, that tight, rigid femoral canal.
Especially that sharp edge of the lacunar ligament.
Exactly. That rigidity is why it has that shocking 50% emergency presentation rate, usually due to strangulation.
And clinically, it's a nightmare to spot sometimes. It appears below the inguinal ligament, often lacks that classic cough impulse.
And frequently gets mistaken for just a swollen lymph node. Or even worse, it presents as a Richter's hernia, where the bowel wall is dying, but the patient doesn't have obvious obstruction symptoms, leading to critical delays.
Which means if you find one, repair is absolutely mandatory and urgent. No watchful waiting.
None. And the surgical approach has to match the risk. In emergencies with suspected strangulation, the high open approach McEvedy or NIHUS is often the standard, because you must have safe access to potentially resect bowel.
While laparoscopy, especially TAPP, is becoming increasingly valuable, both for elective repairs and potentially for emergency diagnosis, and particularly good for avoiding misdiagnosis in women.
Correct. It helps ensure you're fixing the right problem.
So we have the situation, a potentially lethal condition that's hard to diagnose clinically, often only confirmed by urgent imaging or when the patient is already in an emergency situation requiring complex surgery. This leads us to a final, provocative thought for you to consider, building on that surgical urgency.
Yeah, think about this. Given how difficult clinical diagnosis is and how devastating the consequences of delay are, especially with Richter's hernias, how could technology change this game?
What if, for instance, we had widely available, portable, maybe even AI-assisted ultrasound? Something that didn't rely so much on operator skill and could reliably tell the difference between a small, tensed femoral hernia sac and a lymph node right there at the bedside or in the clinic.
Could that kind of technology essentially eliminate the diagnostic delay? Could it shift that massive 50% emergency cohort into the planned elective repair category? If we could guarantee early, accurate diagnosis before strangulation sets in, would that fundamentally alter the entire management pathway for this dangerous condition?
Something to definitely think about, how advanced accessible imaging might one day neutralize one of surgery's most silent and deadly anatomical traps. Thank you for joining us on this deep dive. We hope this exploration has been valuable.